I'm just honored to be up with this panel. I think that it is, it's interesting. The field, it's a comment that the field needs to grow, both from funding and personnel, because we all know each other by first names, and have worked with each other usually in some way. Well, I want to be able to synthesize this, but I think one of the best ways of doing that is actually asking you guys if you want to, first of all, if you ask a question, you get to stretch by standing up and asking your question. But if you can, before you ask your question, also say who you are and where you're from, because it helps us to get to know you as well. So I want to open the floor for questions from the group, or questions or comments from the group. And we're going to be, if you can keep your questions kind of short and to the point, and that way we'll get as many people on as possible, that would be great.
Thanks for your presentation. My name is Li Yang. I think you talk about the intervention and involve a lot of occupations. And if you look into our society, the problem is executive problems caused by those occupations. Just about any occupation, they harm our society. So I just wonder if you can really investigate those occupations, whether they are in an institution like University of Maryland or in hospital-based or in police department. They are so secretive. They don't release any information, whether there's patient data or the police their name, who report the violence or who report the injuries. The problem is caused all by those, even social workers, psychologists, just about anywhere. The problem is they don't disclose the real truth, and the society is harmed by them because they victimize everybody, whether you are grandparents or whether you are children or elderly or toddlers. So unless we allow the patient to talk, what that means, they don't allow people to talk, whether that's in the city council or county council or general assembly or federal agency. They don't allow people to talk. If you talk at all, they cover it up. So all the truth is covered up. So all the presentation may be biased. You can have a control group, you can have an experiment group, and a lot of things, even though those data are really manipulated.
That's interesting, because I hear thank you very much for your question, and I hear two questions in there, if I also can paraphrase. One is the availability of data for study is limited, and we know that the data we're getting, even if most recent information about possibly the CDC data not necessarily reflecting what it needs to be. And then to Dr. Betas's point, hearing from people in a qualitative way and opening up the data to people who are actually impacted by the problem is another area of research that we have to do. So we're actually coming about it from unobtrusive data and highly obtrusive data. And thank you for your question, and I'd like the panel to be able to answer that in this.
So I guess I'll, you're exactly right. In an ideal world, we would all have access to the data that's available. In our experience in Milwaukee, the most important thing is building partnerships and trust between different entities. So with hospital level data, we have HIPAA issues, right? So we can't share personal medical information. That's completely illegal to do. So we found ways to de-identify it, found ways that can really address the HIPAA situation. So involving public health departments, they can request data and kind of get around some of the HIPAA elements or barriers. So getting the public health department within your city, within your state involved, I think is really crucial, because that can break down a lot of barriers. With law enforcement data, there's lots of politics that go on with sharing data, but law enforcement isn't, police are not the only ones who have that data. You also have the district attorney's office, and there might be someone there who's passionate about the same topic. So I think a lot of it is really building those relationships. and then cultivating them and continuing to maintain that trust that we're all working for the same thing. We just want less kids to be injured.
And then, Dr. Betis, in terms of hearing things that were surprising or important to get from end users and people that are most affected by our issue, I think maybe you can give an example of that from our learning of your research.
Yeah, say a little bit more about what you were thinking about.
Thinking about qualitative research eliciting some of the important aspects of what we do in a way that you can't get from numbers and you can't get from statistics, but change the path of what you're doing.
Yeah, I mean, my sense of the qualitative data is that it allows us to really understand information that the quantitative data, which may or may not be biased, we never get fully representative samples in the data that we collect. It just allows us to understand the richness and the mechanisms and the why. And, you know, I think that Dr. Levas's points I would echo what he said.
Question?
Yes, I have, is this on now? Okay, I have two quick questions. One is very quick, and I'll ask that first. I'm Carol Pearson, I'm with the Voice of America, I'm a health reporter. When you talk about most people buy guns for self-protection, why then would they want to put a lock on the gun? Why would they want to store ammunition in one safe and the gun in another safe? My second question, and this goes to the last speaker, I really hope I'm wrong, but you said things were hopeful. However, when you look at pre-injury and the whole situation, and you have household dysfunction, children may be victims of domestic violence, may witness domestic violence, they may be exposed to drug abuse, they may be exposed to seeing loved ones killed, they may develop attachment disorder, they certainly may develop PTSD that could follow them for their lifetime, and they may develop mental illnesses based on their environment. How can you address this when mental health services are so expensive that they are beyond the capability of most normal Americans, and you need to have intensive trauma therapy in addition to other services to continue people in their education and avoid them falling into drug abuse?
I'll handle that if you don't mind. For the first one, I think regardless of family and households' interest in the myriad of reasons for which they own guns. I don't know a single gun owner in the country or a single family in the country that wants that gun used by their depressed teen or by their toddler. And that's the reason to talk about why families need to store their guns safely. And that is the common ground around that piece and why the safe storage needs to exist. So there's ways to talk with gun owners and gun owner groups on how they can have both of those things be held true at the same time. How can they feel that they can own their firearm and use it appropriately for sport or use it appropriately when they feel that they need it around for protection, and also hold it in truth in the same place in their head that they also are ways to keep their toddlers, their depressed teens, and their kids' friends from taking that gun and using it inappropriately by not having it been secured properly. That's the first part. The second question I'll take just briefly as well is why is there hope on this? There's a couple of reasons to have, I think, a lot of hope. One, mental health is complicated, and this is a complex issue. Our nation with innovative science has solved a lot of really difficult issues. Our health system and rigorous science with a lot of investment has figured out a way to have our immune system actually fight cancer currently. So this is a complex problem, but the idea that this problem is too complex for us to solve is simply garbage. I will say it often. There's no reason with proper investment that we can't figure out how to get our head around a complex problem like this. And in fact, even with almost no funding for the past 20 years to do any of this work, amazing groups around the country have bubbled up with innovative solutions, have put them into place, and have begun to find effects with even small programs along the way. And to your mental health question, back to what we know, we need to draw on the literature that we know, which is vast, which can inform this specific problem really importantly. Mental health is complicated. Substance use is also complicated. From 1950 to 1970, the country thought that in order to be treated for addiction, you needed to spend 3 months away in a Betty Ford sort of model and be inpatient. We've since learned since then that there's a whole bunch of treatments you can do for substance use that are just as effective with much less resources, with briefer interventions, with briefer touch points, and those models can be put into place to deal with complex situations like this. And that's why I think there's hope. But in order to understand that model, we have to invest in it and take the folks who are in this room and get them to be thinking about those innovative solutions and then give them the funds to actually see whether their programs actually work with rigorous outcomes in science.
I'd like to echo off.
Well, okay, Kyle just had his face at the mic first, and then you can go ahead.
Head nod is what works.
Exactly.
I have two thoughts to that. So my first thought is that since I've gotten involved working in violence prevention, folks that work in public health, we like talking about upstream interventions. And that's kind of what you hinted at the start, that things start really early, and how do you get a hold of that? The more that I've been working with patients and doing this research and talking with survivors of violence, to be honest, I've reached a point where I don't know where public health starts and regular healthcare begins. It seems like there's a tremendous amount of overlap. So we are always, anything we do in health, there's no silver bullet for anything. And the example that I like to use the most is if you think about heart attacks. We all know that if you have a heart attack, the first thing that you do, and the first thing that EMS is going to do when they get there is they're going to give you an aspirin. And aspirin is well known to be life-saving in heart attacks. It is undisputed. Do you know how many patients you have to give an aspirin to save a single life? 42. The number needed to treat for aspirin is 42. So whenever I hear people talking about public health interventions, especially around violence, we seem to have this very different standard that we want to get to perfection immediately. Whereas with heart attacks, we started out with aspirin, and then we got stents, and then we got statins. And it takes time and effort for this complicated issue to start layering on the different interventions and safety and protective factors to get where you want to go.
Quick comment about your first question. I think you raise a really good point, which is, both some of these national surveys that Harvard has done and also Johns Hopkins, Daniel is sitting in the room, they have shown that traditionally when you look at the trend and ask people why they own a gun, you can see an increasing trend in people citing self-protection as the reason to do so, compared to maybe 1980s and 1990s, where a smaller fraction was due to self-protection, a larger fraction was sporting and hunting, etc. So your question is a good one, which is why would they ever want to store those guns locked and unloaded? And I echo what Rebecca mentioned, but also I want to add that there's a large number of gun owners that have more than one gun. They have several guns in their household. And talking to many of colleagues who have worked in this area and those who are very knowledgeable in this area, they have mentioned that many of these gun owners treat maybe one or two of their guns and those guns that may be used for self-protection, keep them loaded, unlocked, and there are multiple other guns in their household that they don't serve that function. Now, ideally, based on the recommendations of the American Academy of Pediatrics and other medical organizations, especially when you have, let's say, a depressed teen in home, you want at least temporarily all those guns to be removed. But if that's not the case, there's a possibility of storing as many of them safely as possible because of the likelihood of suicide. So I think there are avenues in terms of communications to communicate those points to gun owners that would be convincing and compelling for them, despite the fact that many of them do consider gun ownership as something that's essential and integral for protection.
So I just wanted to kind of echo what Rebecca was saying about the importance of mental health and how things not everything's going to be perfect in, as far as how things are funded and in what order we start addressing. It doesn't have to be all addressed at the same time. For us, we just received a large amount of funding from the Department of Justice to expand programming. And the biggest part of our proposal was addressing our blind spot with mental health. So I think that the community's knowledge and the funders' knowledge and our health system's knowledge about how important mental health is to this issue is evolving, and we're starting to see it in what is being funded too. So we will now have a mental health worker embedded on our team so that we don't have to outsource that stuff anymore.
And we're doing the same thing at CHOP and have found that 89% of the boys who are in our program said as one of the goals that they had for the program, mental health. 89% of African American boys in our program said mental health was a goal.
So as a child psychologist, I didn't mention that by training I'm a psychologist. This is all music to my ears to see an emphasis on mental health. And I just want to note that there's a number of evidence-based practices that we can draw from to think about treating trauma, such as trauma-focused cognitive behavioral therapy. And while I agree that there's a great need for additional mental health services, there's some really bright spots. For example, in the city of Philadelphia, they're implementing trauma-focused CBT and another intervention that's secondary prevention across the city for traumatized youth. So I'd encourage you to look to some of those bright spots to think about how we can learn.
David Grossman, Kaiser Permanente in Seattle. I just want to make a quick reflection on what Kyle said about number needed to treat for aspirin, and just reflect it as I did some similar math based on Sherry Barkin's study that you showed, Renata, with an absolute relative risk of 2%, corresponding to about a number needed to treat in her study for about 50. So, which brings you into the same space. And I think your point is valid, which is that behavioral medicine studies, I think by definition, have an uphill battle in convincing probably skeptical clinical audiences about the efficacy as well as the magnitude of effect of their interventions relative to some medical studies. And so I think keeping in mind and being able to bring those together is a good thing. But what the comment I really wanted to focus on here is I'm sort of thinking 15 years ahead. So what's going to move health systems really to adopt violence intervention programs or safety lock programs as you're describing? And Renata, I'm delighted that you're doing the study that you're doing, which is an implementation science study to replicate some of the findings of the Barkin study, which aren't necessarily consistent with findings from other groups. And I think it's one of the things that as we think about what will move health systems, it ultimately will be robust clinical guidelines that meet the standards of the NAM publication around guidelines we trust. And that really means that systematic evidence reviews, high-quality systematic evidence reviews, ultimately will be the foundation for what will be those robust clinical guidelines. And I think more and more professional societies in the clinical treatment as well as prevention realm, as well as groups like U.S. Preventive Services Task Force, have adopted those approaches to thinking about guidelines and are no longer relying on single studies to make clinical recommendations. The issue, and I think the problem that, and again, given the scarce resources in the field and inability to generate large quantities of studies, makes it, I think, imperative for this field to really be careful about how the incremental study that's added will add to a systematic evidence review. One of the areas that we've learned from the U.S. Preventive Services Task Force and behavioral medicine studies is that there's a real strong problem with behavioral interventions to the extent that behavioral interventionists often use very different outcomes, both in terms of process outcomes as well as health outcomes, as well as the heterogeneity of the intervention can be so broad, makes it extremely difficult to actually synthesize the data to understand whether or not in the end they're effective. And I submit that as a challenge for this field, and given the emergence, I think, of an extremely robust cadre of investigators and superb presentations, is what opportunity do we have to align around outcomes and processes, as well as standardizing to some degree the interventions, so that we can avoid some of the problems that we've seen in the past with behavioral medicine interventions?
I was going to ask that you mention it.
Go ahead.
I was going to ask that you mention it.
Oh, okay. So one of the goals of our research work group for the National Network of Hospital-Based Violence Intervention Programs was to formulate a set of common outcomes for the programs, and we embarked on a study that is just recently accepted, not quite published. Actually, just was published on using a Delphi technique to decide what outcomes we thought were meaningful and measurable for the programs, and they were not always reducing death and reducing firearm injury in the future, because that's hard to measure, especially in children, as we said. So we've come up with domains that were agreed upon by most of the programs that existed at the time, and then we found measures that would match those domains of outcomes. And so we're thinking in that similar line, that we need to have, there's a database that we're trying to work on that will be collecting those data, hopefully from multiple programs, and the outcomes that we've developed that would be similar between programs. So thank you for validating the couple of years of work that we've tried to do on that.
Okay. I have a question.
Can I add one?
Yes,
Sorry.
please. No, you're not allowed to add anything.
So I want to completely echo the data harmonization process again by funding a network, in an NIH model that we do for any other disease system in this country would solve that exact problem and give you the funding that's needed for that. And then the other thing is to your number needed to treat. For Safer Teens, the number needed to treat is 10. And we published that in JAMA in 2009, and we replicated it again in about 2013. So we need to give 10 youth who come in through the emergency department a 30-minute intervention to prevent them from having one more incident of violent occurrence, not necessarily injury, but their next violent interaction over the next 6 to 12 months.
Sorry. So I have a question from an online viewer. Can you speak to the role that the American Academy of Pediatrics plays, if any, in fostering practitioner and health system attention to violence?
So the American Academy of Pediatrics, they have a council on injury and violence prevention that is actively working on recommendations, and traditionally, that group had been focusing on car seat injuries and other types of injuries, but more and more attention has been coming to gun violence. I think that the American Academy of Pediatrics has a large and important voice in recommending screening. Right now, they're talking about having screening in primary care clinics. The trick now, though, is how exactly to do that. And I think we saw a couple of presentations earlier that there's not always, just because the American Academy of Pediatrics says something should be done doesn't mean that it's always going to be adopted by every system out there. But I do think that there is a board and a governing body at the American Academy of Pediatrics that is actively looking at these issues.
And there's also, okay, no, you're the panelist. I'm just...
I would also add that the AAP has really, supported large effectiveness trials. Actually, Sherry Barkin's study was done in the PROS network, which is part of the AAP. And so I think we need more rigorous effectiveness and implementation trials, and that's another way that they can support that.
I'll just make a comment just more broadly about physician specialty societies in general. If you think about it, the AAP is an organization that represents pediatricians, and that's what their goal is. I've noticed over the last few years that a lot of different specialty societies, the AAP's kind of been at the front of this, are starting to come around and starting to look at gun violence more through this issue. So the American College of Surgeons, the Committee on Trauma, has been very progressive and has been starting to look at this issue quite a bit in the last couple of years. Just about 2 weeks ago, the American College of Emergency Physicians we had a ASAP Council, which is the decision-making policy body for the group. We passed a resolution saying that ASAP believes that violence is a health-based problem with health-based solutions and public health solutions, and it passed without any argument and gained no news because we've reached a point where it is now, that is not a controversial thing to say anymore. So I do think that these groups are starting to come along and will be helpful together, but it hasn't quite bubbled up to the point yet that you're starting to notice it as much as you may in the future.
And if I could just add, I think of those types of bodies as part of the outer setting. It's important for them to give signals that firearm violence is something to attend to, but you won't actually see practice change with guidelines or bodies recommending things unless there's actual strategies that are happening at multiple levels to change behavior. So all of these things are important, but they have to come together in a multi-level way to actually see clinician behavior change.
Dr. Cooper.
Hi, Cardinal Cooper, San Antonio. First of all, I want to applaud the panelists on a great discussion. You guys did a wonderful job continuing the excellence that we saw yesterday. And I think one of the reasons to be optimistic about this, how we're addressing these issues is just what you did this morning. I think the issues, the things that my colleague from the VOA voice are just our patients, what we see every day. That's just the nature of the beast that we don't talk about enough. But you guys have done some great stuff, because of the great data that shows what can be done. So I have a few questions for three of you. First, Dr. Avidas, I wonder what is your screening process? Who does that screening? Is it part of your EMR? And is it just through the ERs, or is it via other areas? And then for Dr. Rohani Babar, I wanted to know, do you do an initial screen for our violence program? We did an initial screen that sort of then set up for what will be our intervention process. We sort of tailored our intervention to what we got from that initial screen. So I was wondering if you did that, and do you have support groups for your folks? And we had sometimes you get a bunch of folks in a room and they share a lot of common things. So do you have support groups for your groups? And of course, the usual behavioral health issues, how do you address those? And then finally, for Dr. Cunningham, I could ask you questions all day. You present a lot of great stuff. But in that short segment thing that you talked about there, if you come up with someone who has a mental health issue, that goes beyond that, what do you do? What do you do with those? Who do you refer them to? Thanks.
Probably yours, because I think it's not implemented quite yet, right? So.
Yes, so the question's related to screening. So in the original trial, I don't believe that screening was done in electronic medical records because I think the trial started in 2002. So it was paper and pencil. But all of the work I presented is actually pre-implementation, so it's contextual inquiry to understand how we might go about implementing. And importantly, what I would like to do in the implementation trial that follows is to work with health systems to tailor the screening to fit the particular context of each setting.
Question?
Yeah, so I think those are both good questions, Dr. Cooper. One is that you're absolutely right. So in the intervention that we are implementing right now, there is a multi-phase screening, if you will, process. First, we make sure that the individual actually is eligible to be in this study to begin with. And there are certain eligibility criteria I didn't want to go through because of time. So to give you one example of that is individuals who are living in King County and neighboring counties where actually our support specialists and our team actually can go to those communities because we care deeply about that interaction to happen within the community. So if somebody is not living in that community, we can't provide the program for there because we don't have the resources to send our team all over the state. So that initial screening is done. Then it gets completely tailored on a case-by-case basis, individual by individual basis, through the framework of the CTI, critical time intervention, but depending on the patient's goals and needs. So they will talk to support specialists and they list out of a large menu what they're going to work on, and then it gets tailored toward that particular patient. part of the critical, going back to your second question, part of the critical time intervention is to engage patients' support network to the extent possible, family members, boyfriend, girlfriend, partner, mother. It's actually fascinating in the past 3 years how much we have learned that mothers, what amazing roles mothers play for many of these youth. So to the extent that we can get them involved, we do so. Because of our restricted funding, obviously we don't have a very large team to support our support specialists, but through the MDT, multidisciplinary team that I mentioned to you, multi-agency, we, on a quarterly basis, we bring a lot of stakeholders together to work with our patients and our support specialists to ensure their areas of needs are covered. Did I answer your two questions? Okay.
And to all the mothers out there, go mom. That's okay. We can answer to everybody.
So, thank you, first of all, for your amazing leadership on this topic in a very early stage, which I think inspired many of us in the room to really be looking at this and thinking about it from a hospital and a surgical perspective, which really I think was an inflection point for the field. So that's my gratitude for you, first of all. A couple other points, riffing a little bit off Ali, screening is complicated in healthcare settings. I think we've learned a lot from how IPV screening has been implemented well and not well. I would encourage wildly, as people move towards doing larger amounts of robust screening in healthcare systems, that we do not get to the place that IPV screening currently is, where it is often done by somebody looking at a computer with a spouse in the room saying, no one's hurting you, right, as I check the box off on the EMR so I can move to the next screen. We've tried to do screening when we've done it where a couple different methods. One where a youth or a young adult has an iPad or laptop in front of them where they can confidentially check something off on a computer. They don't even have to be interacting with the healthcare professional in the room, who may bring a tremendous amount of biases to that young person who may look a lot different than they are and may have a lot of ideas about why they are there. And that we found that to be a safer method to do that. On the comment of the healthcare workers or your interventionists and their own personal trauma, I think we've had the staff who are doing interventions with, we find with kids and youth in the ER around this, hear a tremendous amount of things, and they need their own support for whatever program is set up. And I think Ali is talking a little bit about that. And I know the hospital violence prevention programs are really quite good about that as well. And we've set up a series of mechanisms for that, as well as had to do individual interventions to help provide resources to our staff when they are overwhelmed by what they are hearing with their youth and unable to kind of move on from that. To your third question, which was about what do we do with kids that what we're giving them is not enough. And there's a couple answers for that. Again, building kind of on what we know about a screening, brief intervention, and referral to treatment model, which grew out of the substance use literature, SBIRT as it's known. There's always a referral to treatment component for the youth that we take care of in the emergency department. We know that what we do is not enough in a 30-minute session. You know, we can do we have them there. We should do something while they're there. We always give them the end part of any intervention is the referral to treatment. We provide them resources. We provide them referrals. We know, unfortunately, that those referrals to mental health providers don't exist. And their access to be able to get to them in our community is incredibly limited. So building off of that, we're working on a couple other trials right now where we see what we can do to extend the opportunity that we have with them in the emergency department via multiple sessions done remotely. So technology has now advanced. Dr. Carter, Dr. Walton, others on our team are now using remote counseling sessions in a multi-session format to try to step up or step down, actually in a smart trial design, in one case to figure out which kids, how can we give the right amount of treatment to the right kids. So some kids came in with a one-time black eye, let's say. That kid may or may not need all the extensive extra resources, which we know are very expensive. How can we assess those kids along the way after, figure out which kids actually need more, and then try to give them something that they need, because referring them on to mental health might not get them anything. So what sessions could we layer on after that, facilitated by a FaceTime conversation done in a HIPAA-compliant platform to be able to give them texting, remote two-way texting with a health coach that's available at our site for them to go back and forth with. And we're evaluating those more complex designs right now with funding from NIAAA and from NIDA around youth violence programs specifically.
whole new area of research that is really young and very exciting. I'm looking at the time and looking at the number of the people, and I'm thinking there's 1 minute per person for the question and the answer. And so as a consequence, and I know we have ER docs up here too, who are like, bam, 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 so go for it.
It's going to be challenging to do 1 minute. Woody Kessel from the Coop Institute at Dartmouth. First, again, applause and thank you for all of you, the 6 of you, for your thoughtful scholarship in this arena, particularly the focus on interventions. And I think what that highlights is that the health system is an incredible opportunity not to study what's the problem, but how do we affect some solutions to the problem. And I think that's a real value add to this conversation. Yesterday, Evie, Megan, a number of people talked about trying to focus the investigations, to some degree deconstructing. Emmy talked about 60%, 2/3 of gun violent deaths are to suicide. So should we focus on that? We talked about low-hanging fruit. We talked about opportunities. And so I think one question that I have is, if we want to make investments, where are those opportunities? Where's the ROI from your perspective in all of this? And the second question is really, I think one of you talked about it, just to think about, and I'm mindful of Yuri Bronfenbrenner's circles with the individual at the focus. And what I want to ask is, given the fact that you all have been focusing much more on individual interventions, what's the opportunity to scale it up? And just as we were talking about the family, who are the exponents? Where are those opportunities? How do we scale it back up from the individual to the family, to the community, et cetera, et cetera? So what are those lessons learned? So 2 questions. They're not diametrically opposed. What are the opportunities and best ones to drill down with specificity? And then what are the lessons learned from looking at the individuals that we could potentially scale up as community interventions with schools, with churches, with other community folks? Maybe it was you, Rebecca, that not all services have to be delivered in the emergency department. So those are my 2 questions.
Go ahead.
So I'll answer the scaling up part. And one of the things that has struck me recently is that our kids that do the best are the ones where we can identify a strong adult in their lives. And what I mean by that is that, moms are very important, but with the lack of mom being there, maybe a grandmother, a pastor, a coach, those kids that can identify someone that's going to be there beyond our intervention tend to do the best. And for scaling up, that message seems to resonate with the community. When I go out and talk about how when we can identify that strong network for that kid going forward as they grow into an adult, the community really latches onto that. The religious communities latch onto that as well. So I think thinking beyond just the family unit, but thinking of the community as a protective factor is a way that we can maybe push this agenda further and get a lot of buy-in from strong, innovative, smart-thinking community members.
So I think as we talked about, the hospital system is a critical inflection point, a critical intervention point, and I think knowing what we know about the mortality, we have a moral obligation, I think, as health systems and as physicians to be intervening in violence as we know it occurs with the patients that are coming within our health systems. That said, if getting to them earlier before they've had injury is incredibly important, and we know that that's the place from the body of literature around violence research broadly and developmental biology. We know that if we can interrupt some of those cycles and pathways earlier on, we will do really well. So investing, I don't want to pick which is the most important. We need to invest simultaneously in a number of these pieces, but an important piece to invest in certainly are some of the resiliency building components in communities, whether they're effective solutions such as the youth empowerment solution, the YES program, programs that are in schools, working with communities to engage in mental managers and other strong adults. Getting those kids engaged. I love that Eugene is also doing, camps during that time. Getting those kids engaged before they get with the, with a peer set is incredibly important, and interrupting it at that point is really important. It's as important for other types. I want to be careful, this panel is very youth violence focused in some ways, but it's as important for the suicide component. Getting those kids in middle school to have good self-esteem and have good empowerment and be engaged in healthy, positive activities, those are the things that helps them mitigate their risk from self-esteem and from depression. And the psychologist will correct me as I move along this later on, and helps them not lead further down the risk for suicide. So we have to work upstream also.
I have a very brief comment on it. I do think that one thing that would be very helpful for investment is, if you think about it, we've got a couple of different research networks that we've all mentioned. And especially with the NNHVIP, most of the people involved with that network are spending their time as volunteers doing it. And they have clinical jobs and they do research. And one thing that we've been looking at is, how do you put investments into the foundation of the network so that everyone can operate to the top of their license, right? And everyone can do all of the work that they're capable of doing. And, that foundation itself is difficult. And that's one area that you could spur a lot of activity.
A great example of that is the Pediatric Emergency Care Applied Research Network. Amazing work has come out of that, but the infrastructure is funded continuously so that we can make it happen. One question here.
Hi, Daniel Webster, Johns Hopkins. Fabulous panel, really great. I just want to throw out one issue, I think, for future consideration when we're thinking about means restrictions and suicide risk, and the focus coming from early studies about, well, how are teens accessing the guns they use to kill themselves? They're coming from the homes. And the focus has been the locks on the guns in the homes. Over the past 20 years, there's been a tremendous amount of policy and social cultural change in gun carrying. What has changed in the United States is not the number of households with guns in them. What has changed dramatically is the number of people walking around, driving around on a very routine basis with guns. So in thinking about what kind of exchange do we have when you are interacting with a parent and your only focus is how do you store your gun in home, I worry a lot that we're focusing on a problem. Look, guns in the home are a problem, okay, but I think there are new things for a new challenge to address. I don't have the answer to it, but I think we have to be very aware of it and understand it better and hopefully come up with some interventions because it's really a tremendous change in a big swath of the country right now.
For that insight and for all the great work that you do. It's my hope that through partnership with gun owners, we can identify creative solutions that we wouldn't have thought of as healthcare providers. And so I'll give you a call. I'd love to talk more about that, but I think that's very important.
Short of changing the number of guns in the community, which of course is almost the elephant in the room, the number of guns that are out there being able to be used quickly, a lot of the work that you've seen here today is around how not to get someone to the point where they want to carry it and or pull the trigger, right? So it is the head matrix kind of injury prevention, and there's certainly much more work that needs to be done in terms of availability and access. Last question, I'm sorry.
I think to your point also, understanding of those many people who are carrying guns around, which again is not our focus to reduce the number of guns total, but we could certainly do better with good research to understand who was at a particularly bad moment in their life to be carrying a gun. For example, if you're using substances a lot and having a really hard time with that right now, is that a really good time for you to be carrying your gun? Maybe, maybe not. If you have 3 restraining orders out against you for something, and your 2 ex-girlfriends are worried for their life, is that a really good time for you to be carrying a gun? And how do we understand the data around that and have those points be better understood? Because I think those are things that Americans generally appreciate, that those are times that somebody is at highest risk for getting into trouble, and that we want to help that person. And how can we better understand those times? And that's a data-driven policy question that I really am excited that you're going to figure out.
And this is the last question of the session.
Hi, excuse me, Meredith Wadman. I'm a reporter with Science. And I had a question for Dr. Bates. I had a disconnect because your data showed 2% in the end of physicians, primary care, who were regularly promoting or offering free of charge gun locks. But you also said, what are we waiting for? We know the intervention works. Can you what's the intervention that we know works? And then can you talk to me about, I know liability was one concern, but can you help me grasp from your qualitative survey what those other 98% of docs, what their sticking points are?
So as a reminder, this is a pre-implementation study, right? So these 2 health systems are not actually implementing the safety check intervention, which is the intervention that was found to be effective in the original 2008 Sherry Barkin trial. And so we asked them about, we used quantitative surveys to ask them about acceptability and use, and we learned that very few physicians are offering gun locks routinely to their patients, which is not a surprise because you have to find a place to get the gun locks from, correct? They're not just sitting in practices waiting to be distributed. I think that the large concerns raised around the firearm locks are, first, what type of firearm lock should we be distributing? And Dr. Grossman has done some great work around that previously. Who's going to pay for them? So are the health systems going to pay for them? Are the insurance companies going to pay for them? Where are we going to put them? How are we going to distribute them? How are we going to teach people to use them? So they were largely operational questions around how they might be used. But in these 2 health systems right now, it seems some physicians have access to firearm locks and are distributing them, but it's a very small minority.
But the reservations were mainly operational. They weren't about, I might offend this parent if I suggest they should lock their guns up.
We didn't hear a lot of that. It's really interesting. And also the parents that we spoke with did not have that concern. In fact, if anything, we looked at the data comparing parents and non-parents. The parents were really, really into the idea of getting something free at the doctor's office. And there was a concern that, in other studies, you could give a coupon for a cabinet lock, for example, because cabinet locks are much more expensive than cable locks. But I think having something there in that moment and giving it to that family is probably going to be our best course of action, but there are questions about how we get there from where we are right now.
Thanks.
Thank you all very much for your questions, and I really want to thank the panel of amazing people and strong work that's being done. And I am hopeful, and optimistic, and now you can see why.